Hello everyone, welcome to my channel Simplified Dentistry with Dr. Maheen K, and today we'll be discussing trigeminal neuralgia. And trigeminal neuralgia is also known to us as tics doloru, and it is also called the suicide disease. It is also called as a suicide disease because the pain of the trigeminal neuralgia is extremely intense. It is so intense that the patient cannot tolerate it and would want to commit suicide, right? So, by definition, trigeminal neuralgia is a neurological condition involving recurrent episodes of facial pain. So, it is basically a neurofacial pain disorder, and it has recurrent episodes of pain in it in the area of top third of the face or the middle third of the face. Now we'll discuss the epidemiology a little. So, approximately 4 to 13 per 1 lakh people each year suffer from trigeminal neuralgia, and its lifetime prevalence is between 0.16 to 0.3%. High prevalence in patients over 50 years of age, so it's basically seen over the 50 years of age, not before that, usually. And lastly, it is more common in patients who already are diagnosed with multiple sclerosis. So, if a patient is coming up with the symptoms that are associated with trigeminal neuralgia, so it's more likely that the patient already has multiple sclerosis. So, the likelihood of trigeminal neuralgia increases, right? Now, coming to the pathophysiology of trigeminal neuralgia. So, as we all know, trigeminal neuralgia is associated with the trigeminal nerve, and trigeminal nerve is the cranial nerve 5, right? And it arises from the deep area of the brainstem, that is the pons, right? And it has three divisions: V1, V2, and V3, right? V1 is the ophthalmic division, V2 is the maxillary division, and V3 is the mandibular division. The ophthalmic and the maxillary division are sensory, and they provide sensory innovations to various structures, right? However, V3, the mandibular division, has both motor activity and sensory activity, right? So, trigeminal nerve is responsible for the following: sensation of the face, right? And activity of chewing muscles like the masseter muscles. Okay, so now we'll be discussing the etiology or the causes of the trigeminal neuralgia. So, in majority of cases, trigeminal neuralgia is considered to be idiopathic. It is considered that the causes are unknown. It could be for any reason, right? Secondly, compression of the trigeminal nerve in 80 to 90% of the cases. So, this is basically compression by nearby arteries and veins, right? Arteries and veins, right? And for example, we can say that by superior cerebellar artery, right? And the anterior inferior cerebellar artery, right? Vertebral artery and the petrosal vein, right? They may cause compression of the trigeminal nerve, right? Some cases tumors can lead to compression, like there is a space occupying lesion inside the skull that can be benign or malignant, and this in result leads to compression of the trigeminal nerve, right? And compression then leads to demyelination of the trigeminal nerve, resulting into a condition that is trigeminal neuralgia, causing extreme pain and discomfort that could be suicidal also, right? So there is demyelination, right, of the trigeminal nerve, results into trigeminal neuralgia, right? So one last cause is the multiple sclerosis, right? So we have discussed this before, that patients who already have multiple sclerosis, they have a likelihood of getting trigeminal neuralgia. Okay, so what are the signs and symptoms of the trigeminal neuralgia? Trigeminal neuralgia is in sudden in onset, right? And it is an intense, excruciating pain. It could be identified also as a sharp, electrifying pain, right? It is most often unilateral, that is, often affects the one side of the face, right? And it may be associated with short lasting headache attacks, right? And there is an aching and burning sensation prior to the attack, right? So the patient may complain of burning or aching sensation prior to an attack, right? Often described as sharp, jabbing, electrifying, shooting pain, right? It has recurrent episodes and frequency may increase over a period of time, right? Duration is usually variable. It may vary from seconds to minutes to even hours, and mandibular division is the most affected branch of the trigeminal nerve, followed by the maxillary and the ophthalmic branches. The triggers that may cause illustration of the pain would be eating, talking, touching to the face, right, and the facial spasm. The milder form of trigeminal neuralgia is also known as atypical trigeminal neuralgia, right? And the differential diagnosis may be associated with a dental pain, TMJ disorder, or paroxysmal pain of edema of eye, right? Okay, so now we'll be discussing the diagnosis and the treatment of trigeminal neuralgia, and based on the diagnosis, we would usually do the diagnosis based on the history and clinical examination, and it could also be done that MRI imaging is done to rule out any lesions, right? And what would be the treatment of the trigeminal neuralgia? Trigeminal neuralgia treatments come as a first line therapy, which may be pharmacological, right? These are all pharmacological, in which we have carbamazepine, oxamazepine, carbapenem, and phenytoin, right? However, if the patient fails pharmacological treatment, then comes the second line of therapy. What is the second line of therapy? We can give maclofen, and others may be non-destructive and destructive. In destructive, we have the microvascular balloon compression, whereas in the destructive, we have the burn through chemical heat or moisture and glycerol injections.